Hey everyone, it's Lakin. The topic I chose for this case conference was neonatal anesthesia. So this case we did was on a little boy who was up in the NICU. He was born premature at 25 weeks via an emergency C-section. He needed a bilateral inguinal hernia repair and a circumcision done. He was 47 weeks and 4 days for his corrected gestational age. He had a rough course in the NICU. He was intubated 3 times for significant respiratory distress syndrome, a couple episodes of significant desaturations and bradycardia, and also had pretty severe pulmonary hypertension. This little guy was still on oxygen in the NICU. He was on 100% FiO2 at 0.5 liters per minute. So, not the sickest baby, but definitely not our healthy little babies that we think of coming in to get ear tubes. So that's why I chose this case. It was just interesting, a lot of different considerations to take in, and it was a really good learning experience for me. So just some patient information for you guys. Like I said, he was premature. He was now at 47 weeks, 4 days for his gestational age. He was born at 25 weeks. When he was born, he only weighed 0.92 kilograms. And for us that day of surgery, he was 5.6 kilograms. So he gained some pretty good weight over the course of his hospital stay. And he was an ASA 3. His pre-op evaluation, his past medical history included respiratory distress syndrome, apnea prematurity, pulmonary hypertension, maternal history of substance abuse while pregnant. He had an ASD and hydronephrosis. Surgical history, he had none. And you could see his pre-op vital signs there were pretty good. His stats were low, especially for already being on oxygen. So the NICU team decided what would be safest for this baby, and anesthesia too. We had conversations about it that morning. What everyone had decided what would be safest was just to intubate him upstairs in the NICU, where it was a very controlled environment and they had everything that they needed, and just to be sure that he tolerated the intubation okay. So they intubated him, and they did a set of blood gases after that, which you can see there. His last echo before the procedure was about a week. His EF was 66%. His pulmonary artery pressure was 31. And the echo noted that his ASD had resolved as well. His labs looked really good. You can see his glucose was normal, and his hemoglobin was also good for his age. He was intubated in the NICU, like I said. They used a 3.5 uncuffed endotracheal tube, and they brought him down on a special transport NICU vent. And his settings were tidal volume of 25, respiratory rate of 40, PEEP 5, and his FiO2 was at 70%. Here's the list of medications that this little guy was on up in the NICU before coming to us. His fluids were D5 half NS. He was on a diuretic. He was on a little baby Viagra, or the sildenafil, which is for his pulmonary hypertension, as we all know. He was on a couple different breathing treatments, some iron, a probiotic, and Miralax. So our anesthetic plan for this baby was actually pretty interesting because we chose to do a TIVA for a couple of reasons. The first reason was that we had actually a different NICU baby before this case that same day. And the first NICU baby was very healthy, about ready to be discharged. We just had problems during that case ventilating with our ventilator. These ventilators at Sanford Bismarck are much older, and they do not really deliver the small, precise tidal volumes that you want them to. So we knew that we were going to be paralyzing the second baby for the surgeon. So we wanted to keep them on the NICU's vent, which I thought was a very good plan. So we couldn't deliver our gas then through their vent. So we decided to switch to intravenous agents. The neonatologist had also expressed concern about hypotension from our agent. About a month before this, I had done a different NICU baby who was pretty sick, and the baby got pretty hypotensive intraoperatively, and we thought it was related to the SIVO. I was having to give albumin, I was having to give crystalloid boluses, and that's about it, but the neonatologist said even after they brought the baby back upstairs, she was having to treat some of the hypotension. So she didn't love the gas. So we decided we were going to stick with Versed, rocuronium, and fentanyl. And obviously, like I said, the baby was already intubated upstairs. So really all we had to do was get the baby comfortable enough to handle the surgical stimulus. So intraoperative issues, we really didn't have a ton. Anesthesia, we went up and talked with the NICU team before it even gotten down there, so everything went really smooth. Everybody was really calm. It was great. Vital signs were stable throughout the case. Mid-case, we saw that the patient was fighting the vent a little bit. We saw changes through our tidal volume. We had decreased tidal volumes. We had an increased respiratory rate. He was on SIMV, and then we also had increased peak pressures. So we would just kind of take it as it comes, like with every case, and give, fentanyl or rock in response to whatever this baby needed. So totals throughout the case was 82 milligrams of IV Tylenol, 0.6 milligrams of Versed, 50 mics of Fent, and a total of 11 milligrams of rock. He'd also gotten 39 mils of his fluid. The neonatologist was just like flabbergasted that this baby had gotten a total of 50 mics of Fent. She thought that was a huge dose. Obviously, we gave it in 5 mic increments, but he took a lot to make sure he was comfortable throughout the case. So it was really interesting watching her reaction to that. And she was okay. She said, obviously, we got to do what we got to do to get through this case or whatever. But she doesn't really see 50 mics of fentanyl given a lot. And I'm like, well, you should see our heart cases. It's crazy how much fentanyl those guys get sometimes. So he did very well. We decided to leave this baby intubated. They were concerned that he was going to have to be intubated for almost 3 to 5 days after this procedure, but they were actually able to get him extubated that night. So the parents were very happy about that. So I chose this case just because it was interesting, and we definitely don't do NICU babies a ton at Sanford Bismarck, so it was really good. And then it's awesome to have a neonatologist with you because you just learn so much, about these little babies, just picking their brain. So I decided just to cover a couple of pearls about neonatal anesthesia. Just remember that their airways are usually a little bit more tough. They have a large head and a floppy epiglottis. Remember that the cricoid cartilage is the most narrow point on these guys, and that their larynx is a lot more cephalad. You should also utilize a neck roll to help place the patient in a sniffing position. That will help your intubations much more. And then remember that you want a gas leak at about 10 to 20. We don't use uncuffed tubes down in the OR, so the first NICU baby that we did that day, I had actually intubated, and we used a cuffed tube. So we would just size a half size down with whatever the baby needed. But this guy came down with an uncuffed one, so it worked out great. Some respiratory physiology points. We know that their respiratory rate is much faster than ours. Their alveoli are not completely mature. They have a high chest wall compliance, but a much more decreased FRC, so they do not have a ton of reserve. O2 consumption is 2 times that of adults. Neonatal O2 consumption is 6 mils per kilo per minute versus only 3 in adults. And we remember that lungs are primarily made of the type 1 fibers, which are the sprinters, not the marathoners. So again, they get tuckered out much quicker than we do. Remember that these little babies have a much less compliant myocardium, and they're unable to increase their contractility. Cardiac output is completely dependent on their heart rate, as they can't compensate their stroke volume. And remember that bradycardia is bad, and that it usually always follows hypoxemia. I'm very thankful to not have experienced pediatric bradycardia yet, knock on wood, but it sounds terrible. Another really important key point for these babies is temperature regulation. We know that these babies lose heat via the traditional ways, which is evaporation, conduction, convection, and radiation. They have a very large surface area exposed for their body weight, and they have less brown fat, which means they are not able to regulate their body temperature. They have decreased thermogenesis, and they have an underdeveloped ability to shiver up until 1 year, so they cannot compensate. So things that we should be doing is we should be warming the OR, using the pediatric hugger, or keep the baby in the warmer. We kept this little baby in his little isolette, which was nice, warm, and toasty, and it monitored his temperature right there, so we had no problems with that. If I ever have a baby who's not in the NICU, I'm sure to warm the room. I have the pediatric hugger going underneath before he even gets in there, he or she, and I put nice warm blankets on top of their hat and around their head, and sometimes even cover their eyes and just have their breathing tubes sticking out just to make sure that they stay warm and cozy. I just put some points on here about blood loss. It's important to remember that they do not tolerate a large blood loss. So I took this kid's weight and I did his estimated blood volume, which is only 504 mils, which is just crazy. There's just like these tiny little things. So his maximum allowable blood loss would have only been 214, But they say you should never let babies go past 20%, so his 20% would have been 42. We obviously didn't even get close to that. I think we barely had even 3 mils of blood loss, 2 mils, barely anything. So just follow the 4-2-1 rule for these little babies again. Just remember that dehydration can be masked in these babies, and that blood pressure and heart rate are not a good indicator. So look for signs like sunken fontanelle, decreased skin turgor, or crying without visible tears, which is also hard because some of these might be masked by anesthesia as well. So it's just important to be on top of it and be vigilant, as it is with every case. Another interesting point of neonatal anesthesia is retinopathy of prematurity. High levels of oxygen can cause hyperoxic vasoconstriction of the retinal vessels, leading to blindness down the road. Obviously, this is something we should keep into consideration. We have the babies for such a short period of time, but if they don't need the high oxygen, they shouldn't get it. So we should be monitoring oxygenation carefully. We should be proactive in FiO2 titration. Remember that normal PaO2 is 50 to 80 in neonates, and we should titrate an FiO2 to an SpO2 of 90 to 95%. So just be on top of it and be watching it whenever you have a baby in the OR. They don't need 100% just because they're a baby. So like I said, I did not do emergence on this kid. We sent him up to the NICU to be extubated. But when you're intubating a baby, you should be sure that the baby's absolutely ready to extubate, especially these little ones. You should have all of the criteria that you do for a regular patient: adequate tidal volume, respiratory rate, and tidal. Make sure you reverse any residual muscle paralysis and that the baby is showing vigorous and purposeful movements, reaching for the tube and whatever else. You should have emergency medications definitely ready for these kids, and there's your dosages. I had all of my dosages calculated out ahead of time. And then if you do extubate, watch for post-extubation croup on these little ones. So in here, I just put some of the common neonatal intraoperative issues seen by anesthesia providers, and that is hypoxia, bradycardia, hypothermia, and hypotension. Hypoxia, this could be related to a number of things, such as is the tube dislodged, is it main stemmed, is there a lot of pressure from the surgery on the abdomen that's decreasing your FRC and tidal volume? Bradycardia, is it related to hypoxia? Is it related to your volatile agents? Or is it related to your sucks? Hypothermia, obviously you should be watching their temperature super close and being proactive in warming the baby. And hypotension, is it related to the bradycardia or are they volume depleted? So the article I found explored doing spinal anesthesia for inguinal hernia repair in infants and talked about if this was a feasible and a safe method in an emergency situation, like if the hernia got incarcerated. So the incidence of inguinal hernia is now up to 30% in premature infants, and they have a high risk of incarceration during the first year of life. Premature infants obviously are much more sick than regular healthy newborns, and so they carry a high risk of complications from general anesthesia. General anesthesia is reported to be associated with severe cardiocirculatory, pulmonary, and airway-related complications in premature infants, so if we can avoid it, that would be awesome. So this study looked at using spinal anesthesia for these repairs. They used a dosage of using 0.5% Marcaine at 0.1 ml per kilo. They followed 100 infants, 69 had spinal and 31 had general anesthesia. They found that there was no complications related to surgery or to anesthesia in any of the groups, and they were able to reason that spinal anesthesia is a very feasible and safe option for inguinal hernia repair in infants, especially high-risk premature infants. This study also cited that a different study found that the risk of apnea in preterm infants after spinal anesthesia is significantly lower than reported apnea rates in infants after receiving a general anesthetic. So it's obviously safer for baby afterwards, especially if they've been dealing with apneic episodes prior to coming down to surgery. This study also mentioned that caudal anesthesia would be an option as well, and that spinal anesthesia requires a more skilled provider, and that caudal anesthesia is easier. So they said either one would work, would be just fine. So it's just an interesting article and something new to think about, I guess. Here are some pictures of my 2 little NICU babies. I picked this case because it's not something that we do very frequently at this clinical site that I was at, Sanford Bismarck. And so it's always a little bit challenging and a little bit more interesting for me to do these cases. I also love doing pediatric anesthesia, so that was good, and it definitely fueled my baby fever, which one of the anesthesiologists told me was worse than COVID. So this case was unique just because, like I said, very infrequent. Often you're not giving babies paralytic very often, so it was nice to work with that a little bit, and obviously higher dosages of narcotic in. And what would I do different? I don't really know that I would do anything different. I thought it went really well. I would just take what I've learned, especially from the neonatologist, and keep implementing that in my future practice. So it was a great case. And here are my references. Thanks, guys.